Okay, Luke.
Your big dog here, Luke Robinson, the host of FuzzyButts and Friends. Welcome to episode 3 in our podcast. And this episode, only number 3, we're bringing in the other big dog, other big dog, Dr. Phil Bergman. He's the head of clinical trials at the Mars VCA hospital. Dr. Bergman, how are you, sir?
Good afternoon. Nice to see you.
Good to see you. Welcome to FuzzyButts and Friends. Well, Dr. Bergman, what I would like to do today is I'm preoccupied with two dogs and the future. And based on what I've seen and what I've learned over the past 15 years since I first lost my dog to cancer, is that now more than ever, I see a future, let's just say 2030. People are going to be jacked in the metaverse, VR, virtual reality, adjusted reality. We're going to see the rise of robotic pets. People are already starting to adopt them more and more. And my concern is that in 2030, if we don't see a significant drop in the incidence of cancer in dogs, my concern is we're going to see pet parents of the future, pet parents in the year 2030, they're going to be confronted with a simple decision. Do I have the option of adopting robotic pets? I have the option of adopting no pet, or if I do adopt a real pet, there's a 50 to 60 to 75% chance that pet will get cancer. And this is particularly concerning to me and worrisome for the following reason, because I am the father of 3 dogs that I've lost to cancer. And my voice is a little bit shaky because I palpated a mass in Indiana's side this Sunday. We're going through tests right now, so we're rating results back today, but he's dropped a lot of weight, so I'm cancer and potentially cachexia. So as a pet parent who's lost 3 dogs to cancer, and now I'm under the specter of potentially a 4th dog with cancer. So that's 100%. 3 out of 3 of my dogs have gotten cancer. I think it's a very real possibility that pet parents are going to have to make some tough choices in the future about whether they're going to adopt pets. And Ginger, our co-host here, she was formerly the head of the Memphis and Shelby County Humane Society. She comes from the pet adoption world, the rescue world. So I'm sure she is concerned as well that people will not be adopting an already large population of pets that need homes. So that's the future, Dr. Bergman, that concerns me. So based on that scenario, as the head of clinical trials of VCA Mars, paint us a picture of cancer in dogs today. And then let's talk about how potentially the Puppy F Foundation and VCA Mars can work together to prevent that horrifying future.
Yeah, I think it's a great question, Luke. Obviously, as an oncologist, we deal with this on a daily basis. Having done this for 31, 32 years now, it's been remarkable to see what's happened in the world of veterinary oncology throughout that time. I think back to when I was growing up as a young oncologist and going through my training and sort of what was considered state of the art back then. And you compare that to what's happening to today. There's been a remarkable influx of new liquid biopsy diagnostics, a lot of new therapeutics. This time frame right now for us in veterinary oncology reminds me of the mid to late 90s in human medicine, where there was a huge influx of new diagnostics and new therapeutics, and specifically Rituxan or rituximab came on the market, which has completely revolutionized the way that people with lymphoma are treated. And we're seeing those same foundations being placed in veterinary medicine. I think the real dilemma and why we've not had more of those therapeutics come to us is that, you know, a blockbuster in veterinary medicine in the context of what a drug company looks at is on the human side, multi-billion-dollar drug. In veterinary medicine, you know, that's often a $50 to $100 million drug, and that, you know, these are the big non-steroidals and heartworms and things like that. So when companies look at, you know, what's the ROI or return on investment, you know, I think that's a harder calculus because these are incredibly expensive things to bring to us. But even with those obstacles, you know, one of the funnest parts of my job is that you get to see what's coming to veterinary medicine because we're part of all these trials. And it is truly remarkable, mind-blowing what is coming to veterinary medicine, especially in the context of new diagnostics. And then what probably is most exciting is, and we're nearly there, are some of these new checkpoint inhibitors that have revolutionized the treatment of human cancer. And, you know, it's the exact reason why we've now finally seen death rates going down from cancer for the first time. For the last 100 years, it continued to go up. And now we're finally starting to come down. And it's because of the fruits of those successes that have happened in the lab that then get translated into the clinic. And we're on that precipice now, I think, in veterinary medicine.
That's boy, I tell you, I'm glad you're excited because from my perspective, Dr. Bergman, you have, I think, really one of the most important jobs for the pet parents of companion animals. That you're excited. It's a good thing that you're excited. So do you think then, are you saying that there's probably a 30-year lag time difference between veterinary medicine and human medicine in terms of oncology research? Is that your estimation?
You know, it varies. You know, I think you have to look at it, I believe, sort of more holistically. That there are certain things that, you know, we beat the human side, you know, and a classic example is like the melanoma vaccine that I was part of. Another recent example is Silencia, which is a brand new anti-nerve growth factor monoclonal antibody from Zoetis that just got approved a month ago. And that product has come to veterinary medicine before it's come to human medicine. So bravo to those types of situations.
Absolutely, absolutely.
And then, you know, there are other scenarios like, you know, where I brought up Rituxan before. I would love to have a doggy version of Rituxan or a cat version. We haven't had one. We've been asking for one for a very long time. And I think it kind of speaks to the ROI issue that we talked about before. So, you know, it's a struggle that we deal with all the time. And, you know, that said, I think there are a couple scenarios, again, where I think that we are ahead of the curve, but we can obviously always be doing better.
You know, talked to Dr. Berg not so long ago, and we were talking about what he described as a hockey stick since when Malcolm first got cancer and he passed from metastatic bone cancer. And then I started my first walk, and then we began the Puppy Up Foundation. And, you know, there was just really a paucity of really just research and in terms of community organization. And so I'd like to use this opportunity that since our walk and the foundation, and certainly the efforts of a number of other organizations, and certainly VCA, gosh, the great work that you're, we really have seen a hockey stick in terms of awareness and research. I kind of asked you for some numbers. Do we have any idea, Dr. Bergman, how many clinical trials are being done out there for companion cancer right now?
Yeah, so the easiest probable place for clients to go to find out about all those different trials is the AVMA has a trials registry or a database essentially. And what they were basically trying to do with that database was recapitulate what the National Cancer Institute does with their website. And what this AVMA trials registry does is it wraps up all the different trials that are happening in veterinary medicine. So it may not necessarily just be in veterinary oncology. And the VCS, or Veterinary Cancer Society, years ago had their own trials registry database. And that then became the sort of platform for how the AVMA wanted to do theirs. So a client can actually go online, just Google AVMA trials registry, and you'll be able to see all the different trials that are there. The dilemma with that trials registry is that certain companies, they want to remain more proprietary. They don't want to show all their cards, so to speak. And so some trials are actually not listed, and that's one of the advantages and disadvantages of this whole sort of game. And I get it from the company's perspective. Part of me says, can you at least kind of dumb it down or reframe it so you're not, showing all your cards, but at least have that information available in the trials registry. And so we don't know exactly what that number is because, again, some of these things are hidden. And there's no one place that is trying to kind of put all those things together by, say there's a trial that's happening at Ohio State or Kansas State or God knows what. No one sort of takes all those different clinical studies registry databases at those disparate sites and rolls them all up. AVMA tries to do that, but it's dependent on folks sending them that information. But if you go to the AVMA trials registry, there's actually a very large number of clinical trials that are on there. When I looked the other day, there was over 50 or 60 studies that were ongoing there. And so even though we worry that, it's not a comprehensive footprint of what's happening on today, we think it probably captures, 80-90% of the studies that are out there.
Right. Yeah. The proprietary aspect of and non-collaborative aspect of some of the research is frustrating, but for this podcast, we'll keep things very positive because there are so many exciting things, and that's certainly one of the challenges to it. But I know we've kind of jumped around here, but I do want to, you just have so much, so much that's going on. Does a typical week in your life as the head of clinical trials at Mars VCA? What does your week look like typically?
For one, I can never predict what my day is going to be. I obviously have a slate of calls and meetings that are typical, but we're constantly being asked by new companies. Everyone always commiserates about how Zoetis bought this company or this company bought that company, and that's all shrinking. It's not happening. As those mergers and acquisitions happen, brand new little tiny startup companies will start to fill that bottom end. And so we're constantly being contacted by those companies to execute, privacy secrecy agreements. So we don't, nobody else knows exactly what they're working on. And new stuff is coming out constantly. We get approached multiple times a week from these new companies or the current companies that are out there about doing studies on new diagnostics, new therapeutics, new biomarkers. The list goes on and on. And while obviously oncology is what gets me going, one of the other really fun parts of my job is that we're supporting a number of different initiatives throughout sort of the Mars ecosystem. So those include, from the food company side being Royal Canin to Waltham, which is kind of the science engine. And then on top of it, Mars has made a very strategic bet on veterinary medicine. And, I take my lumps from folks about being associated with corporate medicine. And I'm the first, as you know me well enough, that I'm the first to say, yeah, we screwed that up, or we could have handled this better or that better. But what truly energizes me is that, and it's part of why I think you're seeing my name come up on a lot of different publications that have nothing whatsoever to do with oncology, is that we're now, by having all these different ecosystem partners and working together, whereas before they were very siloed and people didn't talk to each other, we're now doing studies that I believe can revolutionize veterinary medicine, mainly because you have the size and scope and breadth of a Mars ecosystem to actually tackle those important fundamental questions. So when I go back to your question of what does a typical week look like, it's a ton of calls and meetings. I still practice on Mondays. I don't ever want to give that up as an oncologist, because every single Monday morning, I always want to go to work. I never want to give that up, much to the chagrin of my bosses. They want me to.
Bless you for that. God bless you.
They want me to stop doing that because we've gotten so busy. But I truly and dearly very much enjoy clinics, and hope to never ever give that up. And so we're constantly working on all the different ongoing trials, setting up new trials. We work with these different industrial sponsor partners, and one of the advantages of our size and scope is that I've never seen a scope of work that's been thrown at us that we can't do. Whether that's a simple lab sample acquisition study, all the way up to what we would call a phase 4 post-licensure trial, meaning like a marketing type of study after you've gotten FDA approval. So yeah, our days they could not look more different because we're supporting so many different studies.
Well, I have come to know you, both Ginger and I, over the past few years, and I do love your candor and the fact that you do see the many challenges, both on your side as the clinician, still a practicing clinician, also part of the corporate world and the research world. And also, I feel like you also see it from our side, the side of the pet parent as well. So I certainly do, in all sincerity, appreciate that you do see that you still are there for pet parents, because we do kind of sit on different sides of the screen, metaphorically and actually right now. What I like and I've come to admire about Phil is the fact that you do represent all of the great leverage and resources that Mars and VCA has to offer pet parents that have had their pets with cancer. But you're also accessible to a small foundation, still relatively small, but still growing foundation like the Papilla Foundation, and that we're talking about potentially on partnering on a study. So a couple of things that I wanted you to go over as well is, how does an organization such as the Papilla Foundation, who represents pet parents but want to do specific research, or say like Tripods that wants to do research in specifically osteosarcoma, or we're working with potentially with another company, 3D Robotics, in designing a rear end limb amputation or rear end prosthetic. So we might want to take that to you guys and say, hey, can we do this? Do a clinical trial for this rear limb prosthetic that we designed. So walk me through the process. How does an organization contact you? What areas of research is Mars, VCA? Are you guys? What areas of research are you interested in?
Yeah, so if I was to sort of take that prosthesis idea, let's talk about it from start to finish. We would ask that either your foundation or whoever the group is that we would be working with, one, we work on an NDA, so a non-disclosure agreement. So that way we make sure that we keep your secrets secret, because that's important to that group that's working on that. And that's something that we take incredibly seriously. When we farm studies out to different hospitals, spend a lot of time talking about non-disclosure and how that's super important. The quickest way you'll never get to do a study again is if you talk outside of school, and that you'll never ever get worked on with again in the future. Once that's then in place, we try to figure out sort of what your goals and interests are. We often then start to talk about a protocol, because the protocol is sort of the Bible for the research. Whenever we have questions, we always go back to that protocol. And, a typical protocol in my world is usually a 40 to 100 page document that walks through every last iteration of what could go wrong, and how does a clinician deal with this scenario versus that scenario. FDA types of pivotal studies to get licensure are often in excess of 100 pages. And then once we've come to an agreement as to what does the protocol look like, what is the budget then associated with that, do we think that we can do it? A lot of that is done in concert with us, because we will then look at a protocol and say, I don't think this step makes sense in the context of what happens in a clinic or an oncology clinic. But once we then all come to terms, there's typically agreements that are obviously executed, and then we go get the work done for that group. And some of these studies literally take a month or two, and then there are other studies that take a year or two. And one of the beauties of being sort of within our organization to get that work done is that we've recently, about 2 years ago, formulated a new group, which I'm really excited about, and has borne fruit in a lot of different ways. And we call it the PCCA, or the Pet Cancer Care Alliance. And really, this was a brainchild of Dr. Tams, our previous chief medical officer for VCA, and now a co-CMO for Mars Veterinary Health. And the idea that he sort of incubated was to get oncologists out of their silos, and one, getting them speaking to each other more frequently, but then thinking about them as more like a think tank. And so really what the PCCA is it's a group of about 20, what I would consider oncology allied professionals. So these are folks like myself as a medical oncologist. There are other medical oncologists from like Blue Pearl. So it's not just a VCA centric type of an approach. We now have medical oncologists from Linnaeus and Anacura over in the EU and the UK. We have surgical oncologists, radiation oncologists, anatomic pathologists, cytopathologists. We have a couple technician representatives, which I'm really proud of, because I used to be a technician when I was growing up. And really what that group comes together to do is to tackle all of these issues that we deal with on a daily basis as oncologists. And we do education efforts. So through what we call WOOF University, which is our online training platform, we've developed a number of basically education modules that hopefully get folks doing things in a very standardized way that improves the quality, meaning that this is how you should do a fine needle aspirate. This is how you should smear it out on a slide. Every last little thing that maybe not everyone is potentially comfortable with in clinical practice. And so it's meant to raise the tide for all boats. And so there's that side of education. There's a number of research initiatives that we're working on. And then the other thing that group has come together, and I think that this has really been a resounding success, is that's now become the platform that then vets these new diagnostics, these new therapeutics. And they then say thumbs up, thumbs down as a group to say that this makes sense to bring into our clinics and offer that then to our clients that have all these pets that are coming in to us with cancer. So the PCCA, I'm really proud to say that I'm part of. I'm kind of the research, wing person that runs that side. But it has been such a successful scenario that we now envision the same thing will happen for neurology and cardiology and those types of things. And I don't think that would be that necessarily easy to do with a smaller group that doesn't have the the scope and the breadth, and potentially then the ability to execute on an idea like the PCCA. So it's one of many things that I'm super proud of that, the Mars ecosystem is doing.
So that's a tremendous value proposition that you offer then, for partnering with you guys for clinical trials. And so in addition to that, you also offer then access to a very large patient population, right? True. So kind of walk me through then kind of the bullet point, the value proposition, the access to the patient population, then the legitimization, from a scientific standpoint. And so what are some of the other things?
Yeah, what we really offer is essentially one-stop shopping for a sponsor, whether that's Puppy Up or a Zoetis, say, for example. So we have the unique ability to give you access, and obviously these all have to go through ethics review and all the other things to make sure that it's truly appropriate to be putting out there, and asking our clients to then consent to doing that with their loved ones. But we have a unique ability within North America, for example, to have access to about 30 different centers, that have varying levels of either just simply medical oncology, or then we have other centers that have med-onc, rad-onc, surg-onc, sort of what we consider to be comprehensive cancer care. And that's been one of the other overarching themes is that we hope to grow these different oncology centers, to have comprehensive cancer care, no different than the NCI or the National Cancer Institute when they do their comprehensive cancer center designation. Because if I have family or friends that come to me that say, hey, I just had my uncle diagnosed with X, Y, or Z, what should I do? And I said, first thing you need to do is find a comprehensive cancer center, that's been designated that by the NCI that's closest to you, because that is basically a stamp of approval by the NCI that this place is doing really, really good work. And we think that that's a good thing to potentially try to recapitulate on the veterinary side.
That's wonderful. It is, and to me, worth the value, right then and there. So, are you limited? And I guess you're not limited at all in any particular areas of oncology research. My guess is if somebody has a proposal or idea, whether novel or not, you go through the process that you articulated. So you're not really limited. If somebody has an idea, just bring it to you, put together the format and bring it to you, right? And that not only includes oncology, but the breadth of all animal medicine. Is that right?
Correct. Yep. So that's
Good.
one of the funnest parts of my job is again, you see what's coming next to veterinary medicine, whether that's a new surgical instrument, a new implant, to a new neurological treatment. But obviously what gets me most excited is oncology.
Well, what's in that vein? What are some interesting clinical trials going on in cancer research that you can talk about? Of course, they're non-proprietary.
Yeah, so you've probably seen the rollouts of some of the new liquid biopsies that are out there.
Yep.
And I while I wish they were perfect, like anything, there's no test that's perfect. And they have varying sensitivities of how easily and quickly they will pick up a cancer. They also use very different mechanisms to find that. And that's why I think the cost is so different with some of the more recent releases that are out there. But to me, if moving forward, if those things can actually be perfected and increase the sensitivity, get rid of any significant false positives, because what scares me, and I do everything I can to put myself into my client's shoes, is that say there's this screening test that gets added on to a blood count and a chemistry screening that happens at your annual visit, and it's one of these liquid biopsy types of diagnostics. The last thing that we want to have happen is that there's a false positive, because when that happens, I feel for my clients because, they're going to go through a lot of emotional trauma and potentially all for naught when it was a false positive. So we have a very keen eye when it comes to those diagnostics coming out, that false positives are minimized, if not zero, whenever possible, because of that emotional trauma. There's a financial context to it, because oftentimes these are patients that are completely normal. They're healthy in every other way that you look at them. And all of a sudden you get this positive screening test, and that starts a cascade of different psychological and financial impacts that are very, very significant. And if it's a false positive, you've just been through that trauma and hit to your pocketbook for no reason. And the same thing's happening on the human side. If you look at some of the state-of-the-art liquid biopsy diagnostics on the human side, they have at best 55% sensitivity, meaning that you're not going to pick up every last cancer when that's happening. So that area of expertise, I have no doubt, will get better over time. But that's kind of the latest thing that's been happening. It's kind of, we went from none of those essentially 5 years ago to now having two and a couple more on the horizon. So it's been very interesting to see how that has taken off.
Is that two, just to clarify, that two different types of cancers that we have the liquid diagnostics for?
No, there's two different groups that have sort of semi-commercialized
Okay.
their products. If you do a Google search, you'll see a couple things come up. One is from a group called Volition, that's kind of working through the team at Texas A&M. And then there's another one that's from PetDx out in San Diego. And I would anticipate more and more of those will come about. Again, the trick is let's lift the sensitivity to have it be more sensitive, and at the same time make sure that we're not having any false positives. And so that's obviously, I think, very exciting, as long as we can make sure that a positive is really a positive. What also concerns us about some of those screening tests is that, as those become more commonplace, right now there's not enough oncologists. Every oncologist, myself included, is right now about we don't see that changing anytime soon. And part of that, I think, was, a lot of folks adopted new COVID, dogs. But it still doesn't completely address for me why oncologists have gotten so busy. I can see obviously the influx of new pups and younger dogs, but how that's automatically translated into the oncologist being so backed up, I don't think any of us completely understand. I'm guessing.
I want to explore that just for a second, and this
Sure.
is important. This is important to me, very personal and passionate to me, because I don't want to go down too much of a rabbit hole about, but the need for board certified oncologists is paramount, because the last dog Hudson I just lost to cancer, we do not have a board certified oncologist here in Memphis. And I believe that what's more important, that yes, general practitioners can administer chemo and do some things, is more important. What's critical, at least is critical in my situation, is what to do when crises happens, or just having the wisdom and the years of experience. And so for me now, I'm sort of on a personal mission to do whatever I can to make sure that there are more board certified oncologists out there in America, because there are big needs. We're sitting right next door oncologists in that state. And I don't think that's the only state. I think Nebraska was one, or I'm not sure if that's changed. It always changes all the time. But so, not to derail the conversation, can do the Puppy Up Foundation to help you guys in our way. We're more on the pet parent side, but Um, I'm a true believer in going to see a board certified, and you're right, boy, 5 to 6 weeks to me is a lifetime. I couldn't wait. I know I happen to have personal connections, but I know that even a week for me is a lifetime. So whatever we can do for pet parents out there to shorten that to just maybe a week or two, I mean, we're on board with. So maybe that's another potential marketing partnership with. Do you guys have a program specifically at VCA Mars that you guys are trying to do more to recruit more or get more certified, or who runs that? I've always been wondering who runs that, the certification process.
Yeah, it's a really good question. So the ACVIM, or the American College of Veterinary Internal Medicine, that's the group that is essentially the umbrella over all the neurologists, all the cardiologists, all the internists, and then the oncologists. And, not to get too far down that rabbit hole, like you just said, but, one of the changes that happened 8 to 10 years ago with ACVIM was that there was a movement to consolidate training sites. Private practice couldn't train as well, which, doesn't sit very well with me. I get that in general, maybe some private practice training programs could be better. But unfortunately, what happened was they tightened the rules and it made less training sites. And so all of us at the time said, we'll have a crisis that will happen. And that's exactly what's happening now, where there's not enough oncologists. And there's really no sort of police for that. The group that oversees that, they don't really monitor market conditions, meaning they don't monitor the number of jobs that are open. It basically just happens with folks that want to do training sites. And so I don't see this problem going away anytime soon. You're very right. There are multiple states that don't have oncologists. And, if there's somebody listening, if they only hear one thing from me today is go get a consult. It is the most empowering thing that you can do to give yourself information about what to do for your beloved pet. Even if you don't decide to do anything, or if you think that you have this idea in your head that you don't want to do anything at all because of X, Y, and Z, many of which are not the most informed decision paths, go get a consult. And while that 5 to 6 week wait is hard, for certain diseases, we're constantly, as oncologists, triaging the folks that we need to speed up getting into us. And that's most frequently lymphoma, because that's such a rapidly moving disease. Thankfully, other diseases, while I don't like a 4 to 6 week wait, it's not optimal, but, having been through this with my own personal health care with cancer, and it's just it's part of the process. It is what it is. We wish it was less. Thankfully, in the end, it probably doesn't make a huge difference, except for lymphoma, because that days are important when it comes to lymphoma. Days or weeks for a lot of other diseases are
Is
less.
that true of both? Pardon my interruption. Is that true of both B and T lymphoma?
Yeah, I mean, it's bad enough with B, but it's even worse with T.
Right. Yeah, I know that, but wow.
Yeah, so we actually will hold specifically a slot or two here or there, because we know that there will be lymphomas that will fill that. So we do our best to get those in as soon as we can. And I have no doubt, other oncologists will say the same.
Okay, yes, that's a rabbit hole. I think that's a good enough discussion about that. Thank you so much.
I do have a question to ask. So is there a mechanism where a pet parent that doesn't have access to an oncologist and the wait is 5 to 6 weeks, is there like somewhere where maybe their GP can send those records somewhere, and you have an oncologist that could give some type of over the phone, like, hey, this is what I'm seeing? Because I think sometimes people would like to have that. When I go on, I'll just say Facebook, there are so many groups with the, you see where my dog was just diagnosed with cancer and my veterinarian said, there's nothing that I can do about it. And, and I have to ask a few questions and I'm like, oh, you got to go see somebody. And then you find out that, I've gone to the VCS website and found, here's an oncologist in your state. I don't know where you are, but, contact them. Is there somewhere where they can get some type of, not maybe immediate, but maybe within a week or so instead of 5 or 6 weeks?
Yeah, so very good question, Ginger. So the things that I would recommend they do would be to go to the ACVIM website. So it's acvim.org.
Okay.
And on there is a specialist locator link. So, and they do that for oncologists, neurologists, internists, oncologists, et cetera. And you then plug in your city or your zip code and it'll tell you who are all the board certified specialists in the specific area you're interested in that are near you. And that at least can help you figure out, all right, who do I contact to go get a consult? In the context of your specific question, what do you do in between? There are some new sort of teleconsultation services that are starting to pop up.
Okay.
I think many of them were kind of born out of COVID because of that issue. But hopefully as we continue to come out of that mess, there'll be less of that. And for me, that was really hard as an oncologist. It's hard enough to do our jobs as it is, but then when you're forced to do it curbside and doing it by telephone or a telemedicine platform, it's hard because what we do as oncologists, that there needs to be an incredible level of trust between both sides. And you can't do that stuff over the phone. It's got to be face to face.
A lot of times it's the first time they're talking to an oncologist. So they have there's not a relationship there to build on.
Yeah. And the other worry I have, to be honest, and it'll be interesting to see how these evolve. When I have somebody that comes into me to do a consult, I'm reviewing a stack of records. There's a lot that goes into that for me to then assimilate all of that. You then do your exam to make sure that your exam fits with all of that historical information that you've been fed. And then you talk about, what's the disease? What does it behave like? Does it metastasize? How locally invasive is it? And then we sit down and talk about what are the tests that we need to potentially do. And then we talk about treatment options and we go through logistics, side effects, estimated costs, what are anticipated outcomes and ranges. And it's why a consult is an hour, because you're literally, working with us for an hour. And so I worry, there's a significant side of me that worries that, will telemedicine really be that significant of a boon that it's, is it worth missing some of those little details? Because at least I found over the last 31, 32 years of doing this, it's those little details that make a huge difference in what you recommend to a client. And, thinking about, all right, here's standard of care. That doesn't work. Here's plan B, here's plan C. And then to the end that I just shared with you, that I implore folks to go get a consult. There is always, always, always something that can be done. Even if it just means palliative hospice type care, there is always something that can be done. And when I hear folks that say, well, I'm just not even going to go see the oncologist because nothing can be done, or maybe they heard that from their primary care veterinarian, I can assure you there is always something that can be done.
Yeah, I notice in those groups on Facebook when people say, well, there's nothing else that I can do. And I'm just like, how old is your dog? What is it? And I'm not a veterinarian and I don't attempt to be one, but it's just the questions that I ask. And I'm like, wow, if because I think I'm lucky, I know a plethora of boarded oncologist, and you all have been so great when I've emailed questions out about my dogs. And it's like, oh man, if they just knew this little bit of information that I had or that you have, it's just something can be done, and it's just so frustrating.
The other thing I would add too is that, for those places that, an oncologist is not close, having trained a lot of residents over the years, oftentimes the internist that is in that area sort of becomes the de facto oncologist. And like when I was training residents at the Animal Medical Center, and we would have internal medicine residents come through our service, I would tell them, I want, even though you're headed towards internal medicine, I want you to pay a lot of attention on this rotation, because if you are in a location that does not have an oncologist, all the internists that I know that are in that situation, 40 to 50% of their what they do on a daily basis is oncology.
Yeah.
So that internist ends up sort of becoming the de facto oncologist. So part of why I give that information is if you happen to live in Arkansas, chances are there's a greater likelihood there are internists in your area, because I think last I looked, there was about 500 oncologists across the world.
Yeah.
There's like 2,500 internists. So don't be afraid to potentially lean on an internist, because they often have a lot more oncology information than you think.
Okay, that's great. That gives me somewhere to point people to if they don't have an oncologist. Thanks for that.
One other benefit before we move on that I'm very passionate about, as you know, Phil, is there's another reason to go get the consult is data. We need more data from cancer dogs. Wouldn't you agree?
I completely agree. We struggle with data a lot. And, we're working hard on trying to perfect that, especially within our own ecosystem. And as you guys are probably familiar with, there's over 30 different electronic medical record systems that are out there. And they all use data differently. Even within a system, in my world, it's Woofware, that's our practice management software. And, there's about 100 different ways that Woofware can be used by the clinician. Some of that is what we call structured data that, you can really depend on. And the rest of it is kind of free form, unstructured data that, you probably have to, what we call scrub, meaning that you have to really investigate what's being written in that record. So yes, we struggle with that. And, and it's exactly why most of the FDA studies that we do now, what we call pivotal studies, where they're looking to get licensure of a new therapeutic or diagnostic, we use an electronic data capture system or EDC system that prospectively specifically dictates what data is generated. And so that's highly trustable data. And so we're working hard on the next iteration of Woofware, what we call Voyager, to make sure that data can be utilized better by the clinician on a day-to-day, minute-to-minute basis, but then also more importantly, thinking about how do we make sure that data is well structured so it's easier for us to either go take a snapshot based on, say, a certain disease prevalence. Maybe there are hot spots of lymphoma in certain areas of the country that we might be able to look at. The other way that we're kind of thinking about that is, can we use it sort of as a sentinel of other situations? And where I'm really headed there is zoonotic diseases, so diseases that can potentially be passed across species. And can you use that practice management software to maybe find things earlier? One of the classic examples I think of there is that, every now and then you hear about a food contamination issue, and they recall that food, or that, say, a certain type of treat was recalled. And one of the ones previously was because of a product called melamine that started causing a bunch of kidney disease. And before that happened, it would have been really cool to have a system that could potentially look for a spike in kidney values. And that way, if we start seeing that, we can be more proactive instead of reactive. So we're working hard on trying to make sure that we have a cogent way of utilizing our data moving forward.
That's very, very exciting because I'm very passionate about data. So we talked about exciting thing, liquid diagnostics going on in the diagnostics area. So what else is exciting going on in the therapeutics? What excites you in therapeutics right now? And are we seeing immunotherapy as well?
Say that again, Luke, I'm sorry.
Are we starting to see immunotherapy filter into companion cancer clinic ward?
Yeah, so we're starting to see a couple things happen. So there are more and more what I would consider to be sort of targeted therapies. And in fact, last week there was a paper published by a Japanese group that got a lot of attention by me and others, utilizing a new drug called Lapatinib. And Lapatinib is a state-of-the-art medication often used on the human breast cancer side that inhibits what's called EGFR and HER2 signaling. These are two normal proteins, but they get co-opted by cancer by either overexpressing them or mutating them. And it basically tells the cancer cell to go haywire and grow more significantly, metastasize or spread. So what this drug does is it comes in and it prevents that cascade of signaling to happen. And so what this Japanese group had found was that this drug was really well tolerated for dogs that had transitional cell carcinoma, the new term being urothelial carcinoma. And what they found is that this drug actually far exceeded survival times that we've seen with any other standard of care, chemotherapy, nonsteroidal anti-inflammatory. So I love advances like that, where we take advantage of technology. So very, very targeted, specific types of therapies. There's new immunotherapies coming, and I can't, due to proprietary issues, I can't go into details, but I have no doubt that you and Ginger and a lot of your other folks that watch these podcasts have seen on TV, these commercials of living longer with your cancer. And these are basically what are called checkpoint inhibitors. And cancers have gotten so bloody smart that what they do is they touch your T cell that would normally attack the cancer cell. They touch their T cell and they tell that T cell to turn off. Really remarkable when you think about how freaking smart that cancer cell is to do that. Well, what these new checkpoint inhibitors do is they screw up that touching, so it doesn't allow them to touch it. So what it effectively does is it takes the brakes off of your immune system. The good of that is it allows them in 30 to 40% have complete disappearance of their tumor. They're invariably cured, those that do have complete responses on the human side. And there's now 7 FDA approved checkpoint inhibitors on the human side, and we're hopefully very, very close to having our first in veterinary medicine. And that's unbelievably exciting to me because, there's no vaccine that goes with that. There's no chemo that goes with that. It's purely giving a drug that takes the brakes off of your immune system. And, the next step, as I've learned from collaborators at Sloan Kettering, where I've got an adjunct position, that it's now taking checkpoint inhibitors and giving it with kind of a traditional type of therapy. But we obviously need our first checkpoint inhibitor, but we're on the cusp of that. And that is, unbelievably exciting. I know that there's a lot of groups that are looking at what are called CAR T cells. So these are basically T cells that are taken from the patient. They then do some genetic things to that T cell. They grow them up in the lab. You give them back to the patient, and they're specifically pre-programmed to then go after that cancer. The problem is they're inordinately expensive. So the trick is can we get the cost of goods to be low enough that that works in veterinary medicine? And one of the ways that, you know, some groups are trying to deal with that is instead of having them be from the patient itself, which is what we call autologous, is actually taking it from one dog and doing that for all dogs, because that greatly lowers the price, what we call allogeneic, so a different dog. The trick is, you know, making sure that they work effectively and they're still safe, et cetera. You know, and then there's like, you know, one of the new advances that has recently come to us is called Stelfonta. So it's basically an injectable, so intralesional drug for mast cell tumors. And what it basically does is it magically makes the mast cell tumor disappear. It unfortunately is only good for certain sized lesions. Plus it leaves a hole there, which is scary to us as veterinarians. So it's forced us to retrain our brain that, you know, normally we see a hole and we flip out and go, oh my God, we got to bandage it and use antibiotics and this and that. And actually they have very good data to show that vast majority of those heal up within a couple weeks. And so there's probably something that's promoting healing that happens with that injection. But what really gets me excited about that drug is that they have some data in mice and some early data in people that suggests there's what we call an abscopal effect. And what that really means is that, say there's a tumor here on my forearm, we inject it with Stelfonta, it makes that tumor go away. But if I had a similar tumor on my opposite arm, because of the destruction of the first one, that turns on the immune system, which then makes you get rid of the one that's over here, or more importantly, makes the ones in your chest, which are spread lesions, go away. And the abscopal effect is the holy grail of cancer therapy. And so if my sincere hope is that, you know, we have potentially an agent that if we prove it has an abscopal effect, that's an agent that goes from just strictly being for mast cell tumor, but likely being used for a variety of other metastatic tumors. And that's crazy exciting that, you know, you could have an agent that works that way.
That's exciting.
Well, that's all wonderful, and it's all very, very exciting. But you're absolutely right that with this, the more arrows that we add to the quiver, these new treatment, all these new, this basket of new treatments, new therapeutics that are on the horizon, the expense of them is considerable. So I can assure you we are on our end working on a solution for that, because as the supply of treatments increases, we have to make sure the demand for those demand for that supply increases as well. And that means more available dollars for those treatments. So we're working on a solution for that. I want to get back to briefly something you said a minute ago about cancer being smart. You know, it's interesting, Dr. Bergman, because I talked to a lot of people on my travels, and it fascinates me that people think of cancer as a static quantity, but it's not. It's always evolving. And that makes its nature's greatest enemy. But it's evolved to the point where it has its own energy supply. It creates its own vasculature to be able to grow and so on and so forth. So I kind of kid somewhere is I kind of kid sometimes and ask kind of metaphysically and philosophically is where's cancer going? What is it evolving to? But it is interesting that it is smart. And it seems like every time we get ahead of it, it seems to trick us somewhere else. Is that right?
Yes and no. You know, I think if you look in the overall context, and if you put this with the framework of death rates, and like we talked earlier, how they're finally going down for the first time, that suggests to me that if we hit them in different ways, that they're not always going to develop resistance against that. And these, excuse me, and that's part of why, if I never had to do a chemotherapy study again, I'd be a very happy oncologist, because chemotherapy is not the wave of the future. And it's why I've said for well over a decade that immune therapy is the wave of the future. If we can, I'm a big fan of always saying that if we can understand what causes an anaphylactic reaction, and it's remarkable what that does. If you can harness even a tenth of that power of what the immune system has and use that specifically against cancer, that's going to be remarkable. And that's exactly what's happened on the human side with these checkpoint inhibitors. The dilemma they have is that these are $200,000 to $250,000 treatments. They only work in 30 to 40% of the patients. So what can you do to better predict who's going to be the lucky 30 to 40% responders? Because throwing that at 100% of cancers probably doesn't financially make sense. And I would predict that we are probably going to be in similar straits, but thankfully, who in their right mind can afford that for a veterinary patient? So my hope is that those costs are obviously remarkably less.
What are you seeing exciting, and to what extent does Mars VCA, are you guys interested in on the prevention side? Because we see, and I talk to a ton of pet parents who always ask, what are we doing on prevention?
Yeah, prevention is another holy grail. And it's hard because the prevention programs that have really been out there that have been most successful on the human side have really spoke to what were the cancer insiders to then get rid of those. And so obviously smoking was a very large part of that, chewing tobacco. And so I think that's also another reason why potentially we're seeing death rates go down, because we're potentially seeing less of those types of cancers. But once you get outside of that area, it gets tough because a lot of the insiders are not very well known. An interesting study that is revolving around that we support is through Lauren Trepanier at the University of Wisconsin. And she has a really significant interest in looking for these inciting agents that are related to a dog or a cat developing a transitional cell carcinoma. And so she has a really intriguing study that we support both within VCA, but we also support it at Antech, because Antech has, you've probably heard of that urine test that's called the BRAF test that has completely revolutionized how we've diagnosed that disease. We now supply all the results that come back from the BRAF when that's positive, or what we call detected. We then say, hey, please know about Dr. Trepanier's study. And what she's basically doing is taking urine samples from both the dog and the owner, which is what's really cool about this. And she's looking for known inciting things that are in the urine that could be associated with food, water, God knows what, to see if potentially dogs may in fact be good sentinels for finding those things in the dog, but maybe potentially before it happens in the person, or vice versa. So it's a very intriguing, to me, kind of one health, one medicine type of diagnostic approach. And I love studies like that.
Yeah, because I read, going back what you said a second ago, I read The Emperor of All Maladies and learned the shocking point from a historical therapeutic standpoint is that the only three treatments were basically extreme surgery, radiation, and chemotherapy, and neither of those three have a tenable long-term or tenable long-term as treatments for cancer. So it seems the areas of the future for cancer research are in immunotherapy, targeted therapeutics. Well, those are kind of the areas. Am I correct?
I completely agree. Yep. I think the wild card in all of those is sort of the prevention side, because I can't tell you how often I have clients that will come to me and say, God, doc, I did all the right things. I exercised my pet. I gave them a really high quality food, cancer. And I feel for those clients because they have done things correctly. And, I think sometimes food gets blamed, which bothers me as an oncologist, because part of how I fight back amongst that, because I hear a lot of anti-corporate food. If you look at the types of cancers that we as oncologists see, we rarely see digestive related cancers. And that's one of the most common cancers in human oncology. And I believe much of why that is because we feed such a good quality diet. I'm the first to know that, I love to grill. That's one of my favorite things. But I know by doing that, I'm increasing my risk of certain cancers because of high temperature causing carcinogens in certain types of even vegetables. I still do it because I try to balance that side of things, but it's a perfect example of how most pets don't eat that stuff. And I believe that that's part of why we actually see it is unbelievable. It could not be more divergent as to how significant the incidence is of gastrointestinal cancers in people, and how, thank God, in veterinary medicine, we just don't see that. And again, I think it's because we feed our pets much better quality.
We don't have that much or as much consistency, but the diet nutrition I found in my travels there's just not nearly enough research in that area. But that's another rabbit hole for another time.
Yep.
So, as we wrap this up, Dr. Bergman, what is a message that you would leave, and sort of the action that you would have for pet parents?
You have remarkable things at your fingertips that you didn't have 10, 20 years ago. And much of that is good. I always say Dr. Google is a good and a bad thing, because sometimes things, go down rabbit holes and people believe certain things that are on the internet that may not necessarily be true. So you have a unique ability to do a lot of that research for yourself. Online through the ACIM locator that we talked about, find an oncologist that's near you. If you don't have one, go see an internist. And I can't reinforce that enough, that it's always amazing to me when I have a client that comes back in for a recheck a year later, they'll have my chicken scratch notes that I had from the first consult. And that information, as I've learned from those clients, they feel that helped them make the right decision for their pet. So I can't implore your readers to go get that consult. It is remarkable the information that you will get from that, and you'll then be armed with all of the options that can work for you and your family with your pet.
Sage advice. One final thing: so you've actually had, not only you been personally, professionally passionate about cancer in your work there at Mars VCA, but you've also personally you've been affected by it, and you're now talking about that. So I wanted to give you the opportunity, if you're comfortable with it, I want to give you the opportunity to talk about that. How the heck are you? How you doing?
I'm good. God, 2.5 years ago was kind of scary, to be honest. I had a single bout of hematuria, or blood in my urine. Went to my primary care doctor, and she said, "Oh, good Lord, you're 55. You don't have any of the risk factors," because the primary risk factor for a TCC, or transitional cell carcinoma, again now called urothelial carcinoma, is smoking. Never smoked a day in my life. And she said, "Oh, don't worry about it. Go home." And I said, "No, that's not how this is going to go. I want you to work me up." Thank God I said that, because as I then started to get worked up, I realized I had a 3.5 centimeter mass in my bladder. I had no signs whatsoever except for that bout of hematuria. And started looking at who's going to become my healthcare providers, and it helped having an adjunct appointment at Sloan Kettering, because I could, be my own, enabler to find those folks. And I also remember at the time reaching out to the head of UC at Sloan Kettering, who I had 4 years prior to that asked to do a keynote talk for veterinary oncologists at a meeting that Craig Clifford and I have done yearly for the last 10 or 12 years in New York City. Little did I ever realize that I would be contacting him for my own personal healthcare, instead of a keynote. And then realized that, one of his fellows was the head of UC here in Stamford, where able to have someone in my local area that was Sloan Kettering, fellowship trained. And he said, we're going to get after this, and you'll see we're going to come out on the good side. And he was right. It's been a long process. It took 2 years, numerous immunotherapies, good Lord, 5 surgeries, but I'm clean now. So that said, I know that I'll have cystoscopies for the rest of my life every 3 months, because I'm predisposed to this. Whatever caused this, I don't know. I surmise that a lot of the formalin that I was probably was in contact with throughout vet school, because when I was in vet school, I worked at the anatomy department at Colorado State on the side. So more than a typical veterinarian has, because you were doing a lot of the expert dissections and all the other things that you do for training veterinary students. So I've long wondered if that formalin was sort of that cause. But I've also learned that you have to be your own proponent when it comes to your own healthcare, and it was a good and a bad thing.
Thank God you're okay now.
Yes, that's
You're
great news.
Yeah, I knew Ginger was worried about you, and she was keeping me apprised and updated with your updates and your health.
As much as I knew.
I'm a tough old bastard, so I'll be okay.
You are, and thank God for that too. But you're a tremendous asset to the pet world, to the companion animal world, and to VCA Mars and that great and wonderful community. And thank you for all the work that you're doing there, and for taking time to be a part of FuzzyButts and Friends. And you mentioned Craig Clifford. Greg's a good friend of mine as well, and I've been pinging him. I haven't heard back from him, but I thought he'd be on FuzzyButts and Friends before you. But you're actually on before him, so I've got a kid with him about that. But thank you so much for your time, Phil, Dr. Bergman. It's great to see you, and we'd love to have you back on anytime, especially if you have some new areas of research, some exciting things to share with pet parents, and anything more importantly that we can do here as pet parents to help Mars VCA, this shared community in which we live. So
yeah, I've been really intrigued with some of the latest discussions that we've been having about ways that we can better work together. And I'll going back to Craig, I'll push him to be on. And one of the things that is really cool, what's happening in his world, is he has recently taken on being the science lead for Blue Pearl. So each of the different banners has a science lead, and
I hadn't heard that yet.
I couldn't be happier that Craig is taking that on. So
he's the man for the job. Absolutely.
We'll do everything we can to get him on.
Yeah,
Thank you.
Great. Thank you. Yeah, I'd love to catch up with him, Joe. I haven't talked to him since he had his second kid too. So I hear he's a handsome lad.
He is a handsome lad. That's Kieran. He's got these amazing blonde curls that he's going to be, I think, a model down the road.
That's right. Well, Phil, thank you so much, and it's great talking to you, and we'll catch up with you soon. And thank you everyone here for being a part of episode 3 of FuzzyButts and Friends. Help you out?